1 in 3 people over the age of 40 is living with chronic lower back pain right now. 1 in 2 women who has given birth is dealing with urinary leakage, and most of them have never been told why. Millions of Americans spend years struggling with constipation, hemorrhoids, and a belly that won't flatten no matter how clean they eat or how many crunches they do. And the answer to all of it, every single one of those problems, traces back to one small, deep muscle that nobody talks about. Not at your annual physical, not at the gym, not in most doctors' offices. That muscle is called the puborectalis. I'm Sam Waterling, and I've spent 15 years watching patients suffer from problems that could have been prevented if someone had just explained this to them once. We are trying to reach 200,000 subscribers on Dr. Waterling, and the reason that matters is simple. The healthcare system is not financially rewarded for making you permanently well. It profits when you come back. Help change that by subscribing and hitting like right now. What I'm about to tell you won't come from your insurance-covered 15-minute appointment. Let's get into it. Let's start with anatomy, but I promise nothing complicated. Your pelvic floor is not a single muscle. It's a layered platform of muscle and connective tissue stretched between your pelvic bones at the base of your torso. Think of it as the structural floor of your body's lower unit. It holds your bladder, your rectum, your uterus if you're a woman, and your prostate if you're a man. The puborectalis is part of the deep layer of this floor, and it has one job that no other structure duplicates. It wraps around your rectum, the final section of your large intestine, like a sling or a loop, and it holds that loop tight. It anchors in the front to your pubic bone. That's the firm bone you can feel at the front and center of your lower abdomen. The muscle travels backward, wraps around the back of the rectum, and pulls, creating what we call the anorectal angle. The anorectal angle is the angle between your rectum and your anal canal. Normally that angle is close to 90 degrees. That angle is not incidental. It is the mechanical reason you have control over your bowel movements. When you're not in the bathroom, the sling stays taut and the angle stays sharp. When you consciously relax your pelvic floor in the bathroom, the muscle releases, the angle opens up, and elimination happens naturally without straining. That is healthy physiology. That is how this is supposed to work. Now, here is where things get interesting, and this is the part most people have never heard. The puborectalis doesn't just control your bowel. It operates as part of a 3-structure pressure system with 2 other muscles. The first is your diaphragm, the dome-shaped muscle just below your lungs that you use to breathe. The second is your transverse abdominis, your deepest abdominal muscle, the one that wraps around your trunk like a wide internal belt. These 3 structures work as one coordinated unit. When you inhale, your diaphragm descends. Intra-abdominal pressure. The pressure inside your abdominal cavity rises, and your pelvic floor gently lowers to accommodate it. When you exhale, the diaphragm rises, pressure drops, and the pelvic floor lifts back up. This rhythmic cycle manages pressure distribution across your entire trunk. When this system is functioning the way it should, intra-abdominal pressure distributes in all directions equally, upward, outward, and downward at the same time. No single structure takes a beating. Your belly looks flat and stays flat. Your lower back is stable. Your sacroiliac joints, the connections between your sacrum and your pelvic bones, move freely and without pain. You walk with confidence. You don't think about any of this because it just works. When the system breaks down, pressure takes the path of least resistance, and the path of least resistance is almost always downward into the pelvic floor. That is when the complaints begin. Urine leaks when you cough. Your belly pouches forward even though your weight hasn't changed. Your lower back aches constantly. Your sacrum, the triangular bone at the base of your spine, feels stuck and stiff. These are not separate problems. They are one problem with several faces, and the face nobody is looking at is that deep sling muscle. Now, let me tell you what actually goes wrong with the puborectalis, because this is where most of the medical world gets it badly wrong. There are 2 opposite failure modes. The first is hypotonia, low muscle tone. The sling is weak and slack. When you cough, sneeze, jump, or lift something heavy, intra-abdominal pressure spikes in a fraction of a second and the muscle cannot hold. Urine leaks. This is called stress urinary incontinence. Not stress as in emotional anxiety, but stress as in physical force applied suddenly. Along with that, the belly pouches because the deep stabilizing system has failed to activate. The pelvic organs start to descend. I want to be honest with you about hypotonia because the internet has made it the default assumption. A woman leaks when she sneezes, and every website immediately tells her to do Keeley exercises. Keeley exercises, squeezing and contracting the pelvic floor repeatedly, are appropriate for hypotonia. But here is the clinical reality that most people miss. Low tone is actually the less common of the two failure modes. Far more common and far more commonly mismanaged is the opposite condition, hypertonia, chronic spasm. In 15 years of practice, the patients who come to me convinced they have a weak pelvic floor are more often than not walking around with a pelvic floor that is locked up, not shut down. Linda came to see me 2 years ago. She was 47, had been constipated for most of her adult life, had hemorrhoids that her gastroenterologist managed with creams and fiber recommendations, and had what her previous doctor called non-specific low back pain. She had been doing Keeley exercises every single day for 8 months because she read it online and nobody told her otherwise. When I asked her to describe how she felt after months of Keel, she said worse. That story is not unusual. That story is the rule, not the exception. Hypertonia means the puborectalis is in a state of constant contraction. It never fully lets go. The sling stays tight even when you're trying to use the bathroom. The inauctel angle never opens up the way it needs to. So you strain, you push. That straining drives intra-abdominal pressure straight into the walls of your rectum and into the blood vessels around it. That mechanism, sustained repeated straining against a muscle that will not release, is one of the primary drivers of hemorrhoid formation and anal fissures. Hemorrhoids are swollen veins in the rectal and anal area. An anal fissure is a small tear in the lining of the anal canal. People spend years buying over-the-counter creams and stool softeners, and the symptom management never becomes a cure because nobody addressed the locked muscle that was causing the problem in the first place. What causes hypertonia? Several things, and in American patients, I see them constantly. Chronic psychological stress is at the top of the list. Your body treats ongoing anxiety as a threat, and one of its primal responses to threat is to tighten the base of your trunk. This is an evolutionary reflex. It protected your ancestors, and it is now creating spasm in your pelvis. Prolonged sitting, particularly in a forward-leaning posture at a desk or in a car, creates sustained compression on the perineum, the soft tissue between your sit bones, and progressively impairs blood flow through the region. Complicated childbirth, pelvic trauma, and poorly coached exercise programs all contribute. And one of the most overlooked triggers, shallow chest breathing. If you breathe primarily with your chest and never engage your diaphragm deeply, your pelvic floor never receives the rhythmic top. Down pressure, it needs to stay supple. It stiffens gradually, the way any tissue stiffens when it stops moving. I want to spend a moment on the back pain connection because this is the piece that the vast majority of spine doctors and orthopedic surgeons are not connecting. When your pelvic floor is chronically locked, your sacroiliac joints, remember those are the joints between your sacrum and your pelvis, lose normal range of motion. The sacrum freezes. The muscles that run along your lumbar spine, your multipedis and erector spina, are the stabilizers of your vertebrae. When the base of the system is rigid, these muscles are forced into emergency compensatory overwork. They stay contracted. The lumbar vertebrae absorb excessive load. The result is chronic lower back pain that does not respond to massage, does not respond to anti-inflammatory medications, and does not respond to physical therapy that focuses on the back because the back is not the source. The pelvic pelvic floor is the source, and that is where the work needs to happen. There is a second downstream consequence of chronic pelvic floor spasm that I want you to understand, because most people attribute these symptoms to something else entirely. When the pelvic floor is locked up, your diaphragm cannot descend freely during inhalation. The floor is too tight, so your breathing becomes shallow, confined to the upper chest. Shallow breathing slows venous and lymphatic drainage from the pelvic region. Veins carry blood back toward the heart. Lymphatic vessels carry fluid that is part of your immune and waste clearance system. When both slow down, blood and fluid pool in the pelvis. The clinical result? Heaviness and pressure in the lower abdomen, chronic fatigue that no amount of sleep fixes, and reduced libido. The cycle feeds itself. Spasm impairs breathing. Poor breathing worsens spasm, and the body gradually accepts this compressed state as normal. Now, I need to stop and address what I consider one of the most widespread and genuinely harmful pieces of health advice circulating on the internet today. The universal recommendation of Keeley exercises for any and all pelvic floor problems. Keeley exercises were introduced by Dr. Arnold Keel in the 1940s as a non-surgical treatment for urinary incontinence in women. They involve repeated voluntary contractions of the pelvic floor. For a muscle with low-tone hypotonia, that approach makes physiological sense. You are strengthening a weak, underactive structure. But for a muscle already in chronic spasm, hypertonia, performing Keel exercises is like repeatedly clenching a muscle that is already cramping. You are not helping it. You are deepening the dysfunction. I have seen patients do months of conscientious Keel exercises and end up with escalating pelvic pain, worsening constipation, and increased back stiffness, because nobody took 10 minutes to assess which condition they actually had before handing them an exercise protocol. If your pelvic floor is in spasm, what it needs is the opposite of contraction. It needs lengthening, release, and retraining through coordinated diaphragmatic breathing. Here is exactly what to do. 2 exercises, no equipment, appropriate for any age and any level of physical conditioning. The goal of both is not to make the muscle stronger in the traditional sense. The goal is to restore its elasticity, its ability to lengthen on demand, to move rhythmically with your breath, and to activate when it is actually needed rather than remaining braced around the clock. Exercise 1, child's pose with diaphragmatic breathing. Kneel on a comfortable surface. Lower your hips toward your heels. Bring your chest down toward your thighs and rest your forehead on stacked hands or a folded towel. Place your palms on the sides of your lower ribs. Now, breathe in slowly through your nose. Feel your ribs expand outward and backward into your hands. Your chest should barely move. Your belly and lower ribs do the moving. Then a long, slow exhale through slightly parted lips. Ribs descend. Lower abdomen gently draws inward and upward. 8 to 10 slow breath cycles. No rushing. Why does this position work? In child's pose, your pelvis is elevated above the level of the pelvic floor that creates a gentle mechanical stretch on the perineal muscles. Gravity assists the release. Each breath cycle sends a rhythmic pressure wave from the diaphragm downward. On the inhale, the diaphragm descends and nudges the pelvic floor gently open. On the exhale, that pressure releases. Over time, this acts as a deep tissue massage from the inside. When you are doing it correctly, you will feel warmth or a sense of expansion in your sacral region, that triangular area at the base of your spine. That sensation is the muscle beginning to release. Exercise 2, deep squat with support. Stand with your feet wider than shoulder width, toes angled outward at roughly 45 degrees. If you feel unsteady, hold the back of a sturdy chair, a door frame, or any solid support. Lower yourself slowly into a deep squat. Go as low as you comfortably can without discomfort. The critical rule: do not tuck your tailbone under. Keep your pelvis neutral. Keep your lower back straight, not rounded. On the inhale, direct your attention to your pelvic floor and feel your sit bones gently moving apart as if the base of your pelvis is softening and widening. On a slow exhale, feel a light, springy lift from the pelvic floor upward. 5 slow, controlled descents, 1 minute of rest, then 1 or 2 more sets. The deep squat is one of the most effective natural positions for pelvic floor release known in human anatomy. Before modern toilets, humans eliminated in a squat, and for good reason. In a full squat, the anorectal angle reaches its maximum opening. The puborectalis sling reaches its maximum stretch, and the muscle receives a clear neurological signal to release. This is why people in cultures where squatting is part of daily life have dramatically lower rates of constipation and hemorrhoids. It is not diet alone, it is position, and it is muscle length. This exercise accomplishes what laxatives cannot because laxatives address the output problem while the structural cause remains entirely untouched. One safety note before you start either exercise: if you experience sharp pain in your lower back or pelvis during either movement, stop immediately. Sharp pain is your body's signal that this condition needs in-person evaluation. Self-directed exercise is entirely appropriate and I encourage it, but it does not replace a clinical exam when your symptoms are severe or progressive. Here is something you need to keep in mind while you do this work. When you are in either position, the objective is never to squeeze or tighten anything. Focus on a slow exhale. Keep your pelvis neutral. No tucking, no arching. Find the sensation of gentle widening in the sacral area. Your body will find its own safe range of motion as your breathing deepens and steadies. Do not force. Do not push through discomfort. 2 exercises every day for 2 weeks minimum, and you will notice a difference. Now, the response of the pelvic floor to stress and its tendency to lock into spasm changes significantly with age. And this is clinically relevant, not just interesting. After the age of 45, connective tissue elasticity decreases measurably. Muscles take longer to recover. Symptoms that were manageable at 35 become progressively harder to ignore at 55. How old are you right now? Write your age in the comments. Because understanding who is watching this channel determines what content I produce next, and the risks and exercise tolerances I discuss depend significantly on where you are in your life. Here is your takeaway stated plainly. One small, deep muscle, the pubo-rheorectalis, controls the anorectal angle, coordinates with your diaphragm and deep abdominal wall to manage pressure across your entire trunk. And when it breaks down, it produces chronic back pain, constipation, hemorrhoids, urinary leakage, pelvic heaviness, and fatigue. In most cases, the problem is not weakness, it is chronic spasm. Spasm worsens with Keeley exercises. Spasm improves with release, lengthening, and breath-synchronized movement. Add child's pose with diaphragmatic breathing and a supported deep squat to your daily practice for 2 weeks. Do both slowly. Stay present with the sensation. If symptoms are severe, find a pelvic floor physical therapist that is a specialist trained specifically in evaluating and treating pelvic floor dysfunction, and get a hands-on assessment before self-directing further. That is the conversation you should have had years ago and nobody started. The system doesn't benefit from you fixing this at home. It benefits from you cycling through gastroenterology appointments and spine injections and prescription creams that treat the downstream effects while the real cause goes untouched. I'm not interested in that arrangement. Subscribe to Dr. Waterling and leave a like on this video. We are pushing toward 200,000 subscribers, and every one of you who shares this gets this information to someone who needs it. See you in the next one.